Now, in terms of the options we have, this is a slide. I like this slide. It's taken from CEC, CPD I took like 5 years ago, but I really, really love this slide to show the history of drug discovery and development over the past century. Actually, Sofina is pretty old. And all the way up to the more contemporary antiepileptics we have now. We'll go through in detail the ones we did not discuss in the previous playlist because, again, talking about lamotrigine here would be redundant because we already talked about it previously. The properties are the same, right? The properties are the same. That's why I prefer mechanism. I try to be as mechanism based as possible when possible. Okay, now, so our focus here will be the drugs who are not used in mood disorders and anxiety disorders, basically. The GABA stuff, so again, very few GABA stuff. Most of the drugs will reduce excitation rather than promote inhibition. Even, again, we're focusing on the drugs available in the Philippines. I know there are GABAergic drugs not available in the Philippines. Actually, a lot of, even if I were to discuss them, a lot of them have been doing really badly to the point I think one of them was withdrawn from the worldwide market if you check out the cheat sheet. And, the others that remain have serious side effects. So I really tend to prefer the drugs that reduce excitation, actually. So like the sodium channel blockers, a special exception, I guess, SV2A. So technically, synaptic vesicle, SV2A is not really an ion channel. So I guess levetiracetam is one exception. The alpha-2 delta binders for the calcium channel blockers, we've already discussed those in sedative hypnotics. Then you have the AMPA and the ones with multiple mechanisms, right? So that's how I try to stratify things. But basically, that's the gist of the range of mechanisms available for antiepileptics. Or, well, again, CNS ion channel binders and levetiracetam. Now, while the carbamazepine, valproate, lamotrigine are used for bipolar disorder, yeah, those are the blanks there, and you have pregabalin, gabapentin as alternatives in generalized anxiety disorder, there are still other neuropsychiatric indications that are not epilepsy for the other antiepileptics, such as, this one I was surprised to learn, like after graduation pa, topiramate, zonisamide. We'll talk about how and why they are used in specifically binge eating disorder. Restless leg syndrome, neuropathic pain, for the gabapentinoids, we've already kind of briefly mentioned those in the sedative hypnotics playlist. Migraine prophylaxis, kind of, touched on that also. And carbamazepines used in trigeminal neuralgia. Okay, now the key, here's the trick to studying antiepileptics or CNS ion channel binders. The trick is, because they all block CNS ion channels, you will expect the side effects will be very similar. So we talk about common side effects, sedation, because, it's again, depressing the central nervous system, sedation, dizziness, headache, nausea, and vomiting still somehow. But, generally, a lot of them will share those side effects, okay? When you study side effects for the CNS ion channel binders, for the antiepileptics, the key side effects to remember are the unique ones, what we call dose-limiting ones, in that when you raise the dose beyond a certain point, you're kind of going to worry about that. Now, of course, yeah, again, pretty much almost all the antiepileptics will have some degree of risk for the hypersensitivity reactions, SGS-10, so Stevens-Johnson syndrome, toxic epidermal necrolysis, right? And even DRESS, actually. So the eosinophilic reactions, a lot of them will have that. So that's already a given. We'll focus on the unique ones. Additional precaution, of course, because a lot of these, it's kind of a drug discovery trivia. You have to check out the drug discovery infographic. A lot of these were serendipitously discovered because they thought that the mechanism for treating seizures was that you needed to deplete folate. So a lot of the earlier drugs were actually developed with the mind of reducing folate. That's why lamotrigine is a dihydrofolate reductase inhibitor, because they got that from phenobarb. But the truth is that wasn't the actual mechanism. But as a consequence, a lot of your antiepileptics, especially the older ones, they tend to deplete folic acid a lot. So anyone who's taking antiepileptics who may be expecting children, you probably want to supplement with folic acid. Right? That's already a given. Now, you will see this especially in pharmaceutical company, big pharma sponsored symposium. Oh, branded is better than generic. Always choose branded. Blah, blah. That's more big pharma propaganda. Because when you look at the actual consensus clinical practice guideline recommendations, they don't say branded is better. Neither do they say generic is better. What do they say? They say do not switch formulation. Okay, so once again, you have big pharma paying people to misrepresent what the recommendations are. It's not pick branded. That's wrong. Rather, we recommend choosing a formulation, whether branded, generic, whatever. Pick one, stick to one. Do not switch. Okay, that's the key there. Whether you're on a generic or a branded, switching either way can lead to the risk is seizure relapse. Pwedeng bumalik yung seizures. So that risk can go either way when you switch from generic to branded, from branded to generic, or from generic to generic, whatever. So just pick one, stick to one. Okay? Do not listen to the big pharma propaganda. The guidelines, this is particularly, I took this from the SIGN, Scottish Intelligence Net, the Scottish guidelines, basically. That is their actual recommendation, right? Just to be clear on that.